in writing and composition. I mean, I remember I think I got a C or a C plus in college freshman
For writing.
composition.
Yeah. And now you write
Yeah.
books.
I mean, everybody sort of pigeonholed me, right?
Yeah.
But, and I don't know if so when I started writing because I got angry. So I got really pissed off when a patient of mine referred her friend. And the friend, very, very smart lady, and we talk about treatment presentation. So I think that this is
Yeah.
relevant.
Yeah. Well, I should introduce it. So we're talking about
Yeah.
case presentation today. Yeah. Our part two. Yes.
So it was in 2010. This woman who was a librarian, very smart lady, comes in, and she tells me that she had been referred to me by her best friend, who had been seeing me since the late 70s. But in the late 70s, when her friend referred her, she said, you know what? I have this great dentist, but he's really expensive.
Aren't they
And
all?
and she wound up going to her union dentist,
Yeah.
and she did everything the union dentist said, even when it was out of pocket. And now, 40 years later, 30 years later, she's developing all these issues, despite the fact that she's been following all the recommendations.
Mm.
And you know what? Now I'm going to go to Michael.
Got it.
Great. She comes in, really nice lady.
Yeah.
And the treatment plan was $60,000.
Mm-hmm.
I mean, her teeth had shifted. She needed perio. She needed perio. She needed ortho. She needed restorative. It was $60,000. And so I always presented the number.
Mm-hmm.
I didn't present how the fee will be paid.
Mm-hmm. The
The
financial
financial
arrangements.
arrangements
Yeah.
were made elsewhere. But
Mm-hmm.
I'm a big believer in the doctor saying, this is what it's going to cost.
Mm-hmm.
And the reason is because you want to look at the person's face. And if then you can step back and say, well, you know what, we can phase it.
Mm-hmm.
Right. We can break it up. We can do phase 1, phase 2, phase 3. Or we can talk about alternative treatments. And I always have alternative treatments. I usually give 3,
Mm-hmm.
including one is always do nothing.
Mm-hmm.
Right. I mean, you're not going to die probably from what?
Yet. Everybody.
I mean, now that we deal with airway stuff and whatnot, maybe. But anyway, I $60,000, and she just started crying. She knew that there were issues.
Yeah.
So lots of people sort of know.
Yeah.
And she said to me, I said, I'm sorry. I gave her tissues, and she said, I just retired, and I didn't budget that into my retirement plan. And I got angry. I mean, I got angry at me because back in the late 70s, I didn't communicate to her best friend that this wasn't expensive. Now, what's interesting is this best friend, I did perio and a full mouth rehab that was still in service. This woman, her best friend, paid little or nothing. I mean, just
in
hygiene
comparison.
visits.
Yeah.
But 30 some odd years. So how expensive was it? I mean, may have been one of the best investments she ever made.
But she didn't probably know that, doesn't appreciate and value that. Yeah.
So, and I didn't have the smarts because I was 2 years into practice. I didn't have the smarts or the experience to know that if with things are going to go well, I mean, her best friend was an amazing patient. I don't think she ever missed a maintenance appointment. So we told her what to do. She did it. She was great at home care. And I don't think I had the confidence. And I think that's part of the formula here. I didn't have the confidence in the late 70s to say, this is going to be the best money you've ever spent, because it's an investment that will pay off dividends for many, many, many years to come. And people will say, well, how long will it last? How many years? And I usually say, I don't have a crystal ball, but I can tell you that I've seen really good dental work, the kind that we do, that is being maintained. I mean, the guy that I was an associate, so my mentor had patients that had stuff 40 years in their mouth. I mean, and and now I can look back. I mean, my wife has stuff that I did in dental school, still functioning. I wrote a piece. I haven't published it yet. I'm debating because it rails against the insurance industry. And I think dental insurance has almost single-handedly dumbed down dentistry.
Yeah.
I've watched it, and I've watched people don't understand. So, I lived with one foot in the clinical, my private practice, and then one foot in academics. So I've seen how things happen. So when I was in dental school, we had to do, I think, 10 units of crown and bridge. I think we had to do, 6 gold restorations, a couple of gold foils. I mean, gold was a big deal. No one does gold anymore. I mean, maybe 1%.
Rarely. Yeah.
Right. I did gold till the day I retired. But the reason was that the government got out of subsidizing dental school. The government used to subsidize dental schools. They got out of the business. Dental school clinics had to be self-sustaining.
Yeah, you got to make money now.
And that meant accepting insurance. The primary insurance in most dental schools, certainly the ones in large urban areas like New York, 80% or more Medicaid. So Medicaid guidelines will dictate what you do. And what you do in dental school will, for the most part, translate to what you do when you get out of dental school.
Yeah.
I mean, that's why we have the Spears and the Coys and the Pankey and the Dawson and the LBIs, because they don't teach that stuff in dental school.
Yeah.
They don't teach it because they can't make money at it.
There's no money in that.
Right. But it's insurance driven. I mean, and then you get out and you join a practice that has a significant PPO percentage in it, and you follow the same formula because you're doing what the PPO. I mean, we've trained, and we can thank our medical colleagues for this. We've trained people to want to basically accept their insurance as payment for what their healthcare needs are.
Yep.
You go to the doctor and ask how much money it is. If you have insurance, it's going to be covered.
Yeah. Just not the same in dentistry. And
people don't understand that dental insurance is not
the same.
It's not really insurance.
Nope. It's not indemnity insurance. It doesn't have these dollars associated.
It doesn't have that catastrophic. I mean, that's what
You have to pay hundreds of dollars a month for insurance like that to pay for a $60,000 case. You know, it's just, hey, let me help you with one tooth every year. Not, hey, let's not go to the dentist for 5 years and then help you get caught up. That's not going to work. In fact, you know, just talking about this and you're sitting on this letter or this article or whatever, you know, I've never helped more offices resign from insurance, in network insurance plans in the last, I'd say 12 to 18 months in a net frame. You know, I'm always helping somebody do that, but never at this level of people, offices saying, doctors saying, I can't do it anymore. I just can't. There's the inflation and the cost of everything. It's just prohibitive now. We're helping offices decide if they want to resign from insurance, you know, through a process, and help them through that process. But the demands for that, coming to and saying, hey, I want to do this, never been higher. Which is great.
Well,
it's a bit of an awakening.
so it is, and that's actually why I wrote the book,
Yeah.
From Hello to Hugs, because you can't flip a switch and go from PPO to fee for service. It doesn't work that way.
Yeah.
So you have to give people a greater perception of value,
Mm-hmm.
and that starts on the phone.
Mm-hmm.
So, you know, we talk about, and I know, you know, All Star Academy has a great,
Yeah.
you
It's all
pamphlet on.
starts on the phone. Yeah. The great call process. Yeah.
Yeah. And this is a way of trying to differentiate, build value, and build relationships. So, you know, when people tell me that their case acceptance rates are low, I don't look at what's happening in
Chair
that
side.
operatory
Yeah.
when the case is being presented. I start off on the website because I want to know what people's so the story about this woman who came in and started crying when she heard $60,000, but she knew she knew that there was something really wrong. She might not have known it was going to cost $60,000, but and I didn't ask. I know people who ask, well, what would you think it was going to cost?
Oh.
I guarantee you, if I said that, she probably would have said 25.
Yeah. $20,000. You'll hear people think the most it's going to be is $20,000.
Right.
Yeah.
Right. But she knew. And that's what we call sort of pre-framing. So pre-framing is what's happening in your marketing that's driving people to the phone, what's happening on the phone that's creating an appointment, and then what's happening when the patient arrives in the office before they even get into the treatment room.
Yep.
So, you know, you know, I've written 5 books. So my first one was called What the Tooth Fairy Didn't Tell You. And it was written after this woman came into my office. And I said, you know what? I need to write something to help people avoid having happened to what happened to this woman. So we made it into a PDF. And when someone was on the phone and they had a specific issue, let me send you a chapter from Dr. Goldberg's book. Before they even got into the office as a new patient, they knew I wrote a book, and they got a chapter of that book. And it wasn't just one chapter. It was the chapter about the problem that they had and about the office. Trying to pre-frame them.
You're preheating them. Yeah.
Right. So look, I moved from my first office was in this lousy neighborhood directly across from the medical center in northern Manhattan. Terrible neighborhood. Scary. I was in a regular apartment building. I mean, you would go in there and you would look to see if there were drug dealers around. I mean, it was scary. But after I left Columbia, I went to Midtown, and my offices were always in these gorgeous buildings. no one comes into that building thinking they're going to get a
cheap
bargain.
cheap dentistry.
That's part of pre-framing
It's
also.
framing it. Yeah, it's framing it, preheating them, getting them ready, and
It's building value.
yeah,
It's
we
all about
we
it's all about
we tell everybody with resigning from insurance. I know we're talking about large case acceptance, but it's really hard to do when you have patients who are looking. When you're in network, you have a certain patient looking for you because you're in network. When you're out of network, certain patients aren't really too worried about that. They might say, "Do you take my insurance?" Sure, we process your insurance claim, but we call them insulators. So the things you're talking about, we make sure they have insulators put in place so that when they're out of network, they don't feel, oh, that family left. They don't feel that. And when we do the PPO write-off calculator, we compare, here's your fee, here's what your insurance, I mean, doctors look at that and they go, what? I mean, the average percentage could range anywhere from 42% write-off to 52% write-off rate for just normal fees in your neighborhood fees. I mean, $62 for a cleaning. And not to mention, Delta sent out a letter to all the California dentists 2 weeks ago saying, yeah, we're changing your fees. They haven't raised the fees in 10 years, and now they're changing the fees. Most of my clients saw 5 to 7% reduction in their overall, what they're going to be reimbursed over a 12-month period. Some fees went up, some fees went down. Well, what's going to happen next year? What's going to happen the year after that? I guarantee you they're not all of a sudden going to start doing 5% fee increases. It's just not going to, that's not their MO.
well, and the reason that you're seeing such an increase in the demand to reduce PPO dependence because you're being squeezed between a rock and a hard place because of inflation.
Yeah.
So we've been fortunate to live prior to 2020, live in an area where in an era where there wasn't much inflation. I didn't have that luxury when I started practice. Inflation was, 15, 16%. It was crazy. But if you can raise your fees, you can cope with that.
You
If
can
you
deal
are
with
a
it. If you
PPO
can't, if you work for
dependent,
the insurance company, you can't raise your fees, even if it's a small percentage, But when everything went up, 8%, clients started saying, okay, I need to figure out my dental supply budget and I need to figure out different things. We're looking at credit card processing fees, all this other stuff. But ultimately we look at, well, how much money is coming in that you're producing, right? Are you collecting all of it? And when you're not collecting it all, you look at it and you go, that's eye opening. And these dentists are not earning enough money to justify their profession. They're making $150,000 and that's just not enough anymore. Just not going to cut it. So team members want more money. You got to give, you want to have good team members working for you, you got to pay for them.
Oh, look at hygienists. I
Yeah.
mean,
Yeah.
it is crazy
Oh yeah.
how many of my clients have had hygienists come to them and say, hey, listen, I wasn't looking for another position, but I got offered something at $10 an hour more than what you're paying me.
Crazy. Yeah.
And the doc looks and goes, what do I do?
Yeah.
And if I don't, $10 an hour let's say it was a $45 an
Yeah.
hour
Yeah.
position. Now that person wants $55 an hour. If you're getting paid $66 for a pro fee and you're paying $55,
do the math.
how many pro fees does that hygienist need to do in a day to justify
how fast do they have to be done? Yeah, you start losing quality. And then you got patients leaving because they don't like the quality. Or you got hygienists who say, I don't want to work here under this pressure, this stress. So you're right. You get squeezed into a place where you say, I don't want to do this. So I think that actually fits into what we're talking about today with case acceptance and the fact that you can't just walk into someone and say, you need a crown. We're specifically talking about large treatment planning, large case acceptance. And last time we talked about just the mental toughness of that. You have to be confident and the patient needs to see that you're confident at first. That's your foundation. You have to believe in yourself before anybody else will see as credible. But now I think today, let's talk about some words, and let's go back and forth just on some things that you like to say, some things I like to hear clients say, and we'll see where it takes us. And I wrote a case presentation formula with a few doctors in 2007 that are mentors and friends and clients of mine. on the East Coast, Dr. Peer and Dr. Morgan, who does some coaching with me, presenting, and Dr. Divine. And the amazing part, what I really wanted to create with them was the understanding that two things that we had to solve. One, people don't buy a solution to a problem they don't perceive to have. So making sure the patient understands what the diagnosis is in clear form is got to be a part of it. And two, people buy for their reasons, not your reasons. And that typically is an emotional reason. People buy with emotion, justify with logic. So we take that emotional why and we lay that as the overtone. And we'll say something like, Ricky Bobby, you shared with me earlier, it was important for you to have peace of mind, important for you to have a quality of life, important for you to have a confident job interview coming up, important for you not to lose your teeth like your grandfather did. Whatever that is, we place that in for their reasons. And then we proceed into condition focused. So do you do something similar to that? Do you have a focus like that?
So, we also call it the patient why.
Okay. Yeah.
And that process of uncovering the why again starts on the phone. And if we can connect everything gets connected to that why. The appointment gets connected to the why.
It's the heart. It's the center of what you're looking for.
Treatment plan outcome gets connected to the why.
Yep.
And then the financial arrangements get connected to the why. That's oftentimes a missing piece.
Yeah.
So oftentimes you'll get the treatment presentation and then it goes into another room for the financial arrangements, and there's no discussion of the why anymore. Now it's all dollars and cents. And that disconnect is oftentimes what allows people the almost permission
to get out and start getting away from it. Yeah. Yep. We actually, when we do the transfer, they have to transfer the why. So I would say, Betty, Ricky Bobby, and Dr. Goldberg were talking, and it's really important for him to have, and then we'll share that why. So when they hear the word important, they know that why is coming, amongst other things, but that's got to be communicated. I love that. I 100% agree. Yeah.
So the other thing about it is, and I think we spoke about this, I never did treatment presentations at the first visit. You can't if you're doing a big case, I mean, it takes time. I mean, I need to analyze, I need to look at, maybe there's a CBCT involved. Maybe I have to wait for the radiologist report on it. Maybe I have to mount models. There are all kinds of things that have to occur before I can really sit down and work out a treatment plan.
Sure.
And like I said, I always present 3 options if I can. And then I try as best as I possibly can to make sure that at that consultation visit where the plan is going to be presented, the significant other is there too. Because, and now if I were doing it, I would even think about having that person on Zoom if necessary. Because, I mean, you want to avoid a situation where I have to ask my husband. Because then what's happening. She or he are going back,
delaying,
and they're the ones that are explaining,
and they can't explain it the same way. Yeah,
they're not explaining the why; they're explaining the process. I need this. The doc says I need this, and this, and it's going to cost $25,000.
Yeah.
Well, why do you need that? They're not dentists. They don't know how to explain it.
Yeah.
They don't know how to explain it.
It goes back to that same rule. People don't buy a solution to a problem they don't perceive to have. And if their husband or spouse is having to buy that solution, they don't understand the problem. Yeah.
What I've instructed a couple of my clients to do, if the patient gives you permission, video it. So if the significant other is not there, video it.
Yeah.
No one else is going to see it. You give it to the patient.
Well, they can record it on their phone. Yeah.
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 And here it is. because otherwise it's a game of telephone.
Mm-hmm. Yeah,
And
it'll just get watered down the more they try to communicate to someone else. We've even had patients. I need to come back with my spouse. Then once we fight for that, and then they still don't bring them in. There's probably a dollar amount where you go, okay, I need to make sure this person. If it's a smaller case, not so much so, but for bigger cases, there's going to be decision makers that need to be present, and so we'll take that why and we'll connect it to the condition. So we'll say, I know it's really important for you to have a confident smile, peace of mind, job interview, whatever it is, and then connect that to, and I'm concerned about, and then we'll start listing out all the diagnosed conditions that are going to affect them achieving their why. And you can't have peace of mind with infection, decay, missing teeth, and here's why. Then we'll talk about the consequence of it. So it goes why, condition, consequences. And all we're doing is laying those three things, putting them together, and asking the patient, how concerned are you with this?
so I don't necessarily ask them how concerned they are.
Mm-hmm.
What I then ask is, what would prevent you from going through with this and getting the result that you want? Let them come up with let the patient come up with the reasons they might not proceed.
The threats.
And so I'm scared.
Mm-hmm.
Okay. Let's talk about that.
Yep.
Because
be in conversation. Yeah.
Right. We don't want you to be scared, and there's no need to be scared, because it's not going to be that uncomfortable. You will never be with some people think, if you're going to take out teeth, I'm going to be without teeth. And one of the principles that we always had was, I don't want you coming out of this office any different than I would want to come out of the office. And I wouldn't want to come out of the office with a front tooth missing. And you won't either. You will never be in a position where you will be either non-functional or unpresentable. So we take care of that if that was a concern. We take care of the comfort if it was a concern, up to and including offering an anesthesiologist.
Yeah. Some sort of sedation. Yeah.
We've done that. I was trained I ran a hospital residency program. So I was trained in sedation. I personally don't like doing sedation because I want to focus on the patient, on what I'm doing with the patient, as opposed to worrying about the person breathing. So I like in New York,
you have the opportunity to do that. Yeah.
Saad Khan, he was our anesthesiologist. He came into the office. The patient paid him directly.
Separately. Yeah.
Easy peasy.
Yeah. So I like that question. What would prevent you from going through with this? I just ask it later, and maybe this is similar to what you do. So first of all, I think we're agreed. Questions are essential to this. You can't move through this without questions. And I think open-ended questions actually are more powerful than yes or no, because people will lie to you in one word. Yeah. Oh yeah, that sounds good. Yeah. And so you want to ask open-ended questions. So here's my flow. How concerned are you with this? Yeah. Okay. You're concerned. Okay. How much sense would it make to talk about a plan and how we can take care of this? Okay, great. Here's the plan. Then you can talk about the plan and what you're going to do to resolve it. Because you found out that they believe there's a problem. If they don't believe there's a problem, there's no sense in talking about a plan, basically. So that's what those questions are set up for. And then once you talk about the plan, then I would say things like, how do you feel about moving forward with this plan? And then I would ask, what would prevent you from going through with this? So we're trying to whittle it down into a smaller piece, but we start really big, no pressure. I'm not a big fan of like reverse yes or no's. Do you see any good reason why you wouldn't want to get this today? It just sounds very car salesman-y to me. I'm not a big fan of that, but I like an open-ended, soft approach that after they say yes to the soft approach, then I can will it. Well, would you like to do it this month or next month? Then you can start getting into more directive questions. So I don't know. How do you feel about that?
Yeah. So look, there's always a fine line.
Mm-hmm.
You-
A balance. Yeah.
between, yeah, you are guiding the patient
Mm-hmm.
to make a decision that's in their best interest.
Mm-hmm.
So first of all, you have to believe it. You,
Mm-hmm.
the doc, has to believe that it's in their best interest.
Mm-hmm.
And I use the line that I think everyone should. Knowing what I know
Mm-hmm.
about dentistry, this is what I would do if it were me or one of my loved
Mm-hmm.
family.
Whittium.
Yeah.
Would I do it on me? Knowing what I know, this is what I would do if it were me, dot, dot, dot. And that's when you're in talking about the plan. So how concerned are you with this? Yeah, I'm really concerned. Would it make sense to talk about a plan? Yeah, here's the plan. Well, knowing what I know, this is what I do for me or if you are one of my loved ones. And then you talk about the treatment. I think sometimes the mistake is doctors start talking about treatment way too much. They spend a lot of time talking about the nuts and bolts of what we're doing here and all the features of this and what lab they use. I have a 95-5 rule, 95% focus on condition and consequences, and only 5% of your time focus on treatment. And you're not even allowed to talk about treatment. It's afterwards. You're not even allowed to talk about treatment unless you know they believe there's a problem, unless you know they want a solution. Now you have permission to talk about solution. Once they hear the solution, how do they feel about moving forward with the solution? Now you get into those questions and be prepared to have bigger conversations. Yeah.
And those conversations can be never ending. I mean, the
I was
fact
just
is,
going to ask how much time.
so so I dealt with, I had a lot of physicians in my practice.
Mm-hmm. Yeah.
That's actually what I'm speaking about
Mm.
in Fort Beach.
Mm-hmm.
I'm talking about physician referrals
Yeah.
because I got a lot of referrals from physicians.
Mm-hmm.
A lot of them were physicians, and they they usually fall into one of two categories. Either they want to know every
Everything.
single
Yeah.
detail,
All the
or
details, just the bottom
I
line.
trust you.
Yeah.
I don't want to know anything.
Just go for it. Yeah. Yeah.
I have a client who's in Huntsville, Alabama, and it's the rocket capital and she has rocket scientists as her engineers, right?
Yeah.
They want to know
Details.
everything.
All the details. Yeah.
But in general, you are absolutely right. There's no way you can. I mean, this goes back to Dick Barnes's
Mm-hmm.
7 slides
Mm-hmm.
presentation, right?
Mm-hmm.
I mean, he didn't tell them anything about the treatment. This
Mm-hmm.
is how you are now. This is how you're going to be. You leave everything up to me.
Mm-hmm.
Now, you have to have a certain
Flexibility.
authority to be able to do that.
Mm-hmm.
But the process that you outlined, I think is great. It's not, I like the 95-5 rule. I don't no, and which is not how we're taught in dental school, by the way.
Yeah, no, that's why I make it an exaggeration, because I'll start working with people 5%, or if anything, on condition and diagnosis. And I'll even say to the client, I'll say, you've heard the saying, before you can prescribe, you must first diagnose, right? Yeah, I've diagnosed. Well, think about it from the patient's perspective. Have they diagnosed? And so we try to flip that and make it an exaggeration and say, focus on the diagnosis more than you ever focus on treatment. And then you can talk about treatment more later. You can get into more details later if you think it's important. The same thing, you can sell a case in 3 minutes and unsell it in 10 minutes. You talk too much about it, they're overwhelmed, they get confused, and people will not, it's a no if they don't understand it. If they don't understand it, it's a no.
Well, not only that, but I think it's so important to keep the why
Involved.
Yeah,
Yep.
it needs to center
Integrated.
stage.
Yep.
It's all it at any of these points, because the natural tendency is to not do things.
Mm-hmm.
I mean, unless someone's in pain, there's a net. You are working against a significant inertia.
Yeah. Here's the I'll show you my screen. This is the formula that we wrote way back when, and you can see it right there why. And it just says, hey, you said it was important for you to have this. I'm concerned about condition, And that leads to toothache or tooth loss, bigger problems. How concerned are you with it? Would it make sense to talk about a plan? Okay, here's the plan. Here's the treatment. Spend 5% talking about it. How do you feel about moving forward with that plan? And I try to help clients understand how simple that formula is, trying to make it really simple so that they can remember to do it. And then you can expand upon it from there. You can develop it from that point. But that's a great starting point just to understand how do you talk to people. And it's not meant to be talked about one tooth. It's meant to be talked about more than one tooth, a quadrant, an arch, a full mouth. I'm concerned about all of this. So, and they've heard it, they've diagnosed, they've seen the photos, they've been involved in the exam. This is after all that. So, yeah.
Yeah. No, I think that that's great.
Yeah. Yeah. We have the ability to really hinder ourselves by holding back and not even talking about concerns. I'll tell you a story. So I have a friend who had a crown done and then had another crown done, but after sensitivity. And it's just, there's still 3 months of dealing with this crown and remaking it and sensitivity and all this kind of stuff. And I just asked my friend one question. I said, was there an old metal filling in there beforehand? And he goes, yeah. And I just explained to him what liquid metal was and how it was wedged in there and how it's not bonded, there's a gap. And he even goes, so basically anything can get in between that and down in there. And I said, yeah, it's just work. It's not eating away at the filling, it's eating away at your tooth. It doesn't want to eat all of it, just wants to eat just enough to survive. Now, let me ask you a question. And I said, do you have more metal fillings in your mouth? And he goes, yeah. I go, are they really old? And he goes, yeah. And I go, are you wanting to prevent this sort of thing from happening again? He goes, yeah. I go, you need to ask your dentist to talk about taking care of these before it turns into that again. I mean, it's that simple. But money's going to play a role, but he has a why now. He doesn't want to go through this again. He does not want to go through this again.
So that's the consequence.
That's the consequence. Exactly.
That's the consequences. And dentists we go into the field because we want to help people.
And we love what we do. And we love talking about what we do.
And so often we shoot ourselves in the foot.
Absolutely.
And I go back, it is hard because we aren't trained the right way from dental school.
Yeah.
If you associate in a, insurance driven practice, you're not changing your treatment presentation dynamic.
Yeah.
Because there's no necessity for it.
Yeah.
So now you're going to go switch to fee for service. Okay. Now you need to change your presentation,
your style. I love your direction.
I love the formula.
Yeah, it's developed over the years, that's for sure. It's made some changes. So just to make sure someone's listening right now, I don't know if we answer this question because I still have my cursor still blinking right here. How much time do you spend with consultations when you have them back? Is there oh my gosh, don't spend more than this much time? It's got to be at least this much. Is there a right answer? Is there a one size fits all, or is it a variable? I know you said a lot of details or whatever you say, Doc. What do you think?
So that's a great question because it goes into scheduling.
Yeah.
So I customized the time based on the case complexity and on the personality of the individual.
Yep. Yeah, completely agree.
I would always tell the front desk. So we had these forms that we filled out. I forgot, a treatment transmittal form. And on the form is how long is your next visit going to be?
Yeah, next visit length of time. Yeah.
So, no one other than the doc put down the length of time because I don't want my front desk to say, well, you said it was going to be this and you ran over. Right? If I said it was going to be this and I ran over, it's on me.
Yeah.
Right. I'd rather it be on me than on
somebody else
anybody
making up
else.
time. Yeah, and they don't know what to schedule for. So X's and slashes and how much time and assistant, doctor assistant, all of that becomes a part of the system. I agree. I wrote down customized based on your time. So DISC, personality type, is a system we use. And then exam typing, making sure that you've exam typed this patient so that even if you couldn't finish it all today, you even had them back to finish the exam and then put the consultation after if it's that complex. I mean, you should never feel trapped by the length of time you have. There's always more time at another visit, especially if it's a large case. So don't feel trapped. So okay, lots we discussed today. Be open-minded. Here, I'll summarize. Be open-minded to large case acceptance, large case dentistry. Don't hold yourself back. And then secondly, don't let insurances hold you back on that. If insurances are holding you back on it, there's a way to deal with that. And maybe that way is being free of restrictive insurance. So, all right. Awesome. And the book.
Giving greater value and better
Yep.
service.
That's right. Absolutely
that's
agree.
the trade-off. There's a triangle. It's high service, high quality, low fee.
Low fees.
That's the you can only get two.
You only get two of those. You can't be all three. That's
So
and I see it all the time. Yeah.
If you want to get rid of insurance,
yep.
you gotta up perceived quality, but up the service, because that's something that people will really feel.
Yeah. There's people out there who love to shop at Walmart, and there's people out there who love to shop at Whole Foods. I call it whole paycheck. So, who are you aligning your type of dentistry with? That's the person that's going to come looking for you. Don't have a vision of, I'm going to do this amazing dentistry and then direct your practice towards, people who are looking for cheap dentistry. That's not going to work. So, all right. Awesome.